Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and good morning to everyone. Okay, today actually we want to continue our topic lesson on assessment related to acute and chronic illness. Okay, actually we already touched this topic a few weeks before. But we actually left about I think quarter or half from this topic to be explained. So all of you record this as alternative for the class. Okay, so actually for assessment related to acute and chronic illness, I just maybe briefly going through again the slide so that maybe can remind and rewind back all of the lesson that we actually learned before. Okay, as we know the learning outcome from this study, we already know that we will understand few concept and differentiation between acute and chronic illness, the causes, and then also the effect to the family, and also the model, biopsychosocial, CCM models, and at last the instrument. So as introduction, we already see the statistic, the figures about the non-communicable disease in Malaysia, and also the definition of illness, the definition of the pain, the examples, okay, the illness versus pain, yeah. And then we also learn about the component of the pain, and also the type of the pain, like the pain divided into acute and chronic, okay. And then the chronic also chronic non-cancer pain, chronic, and then the acute is pre-chronic stages, acute recurrent, okay. Okay. And then we also learn about the table 2, factor in clinical decision making acute versus chronic pain. And then we also look into the psychosocial typology of illness. If you remember the road, okay, this is the road you can see as the beginning. When someone get pain, they will be in the phase of onset and then going to the cause and then outcome, and the last one, the degree of incapacitation. Okay, we actually already touched on the onset, so I just again explain a bit about the onset. So for those maybe who are not maybe listen in our class before, maybe can understand from this video recording version. Okay, for onset, as I said before, it's the beginning of the illness, of the pain. So the family start to adapt with those members in the family or sibling who having that illness. Okay, as we can see from the slide here, the total amount of family adaptation might be the same for both type of illness, acute versus chronic. It is similar. When family maybe get to know their members having acute or chronic, both they have the same amount of adaptation. Okay. For acute illness, as we know that acute, something that suddenly happen and maybe in a short term, okay, so these affective and instrumental changes are compressed into a short time. This will require a family more rapid mobilization of crisis management skills, okay. So at that time, family have to quickly mobilize, quickly adapt, try to learn how to solve the problem. As an example, maybe your children suddenly get flu, fever, or maybe coughing, this is actually, as a parent, maybe you need to quickly maybe adapt with the condition, the situation that happen in your house. Okay, and then family that are able to tolerate highly charged affective state, exchange clearly defined role flexibly, problem solve efficiently, and use outside resources will have an advantage in managing acute or onset illness ni. Okay, so as I said before, when family they are very maybe easy to adapt, with the condition, or maybe the family get as you write in the slide ni, outside resources, like maybe asking their grandparent to help to take care of the children, or they maybe affective state like worry, sad, tired, they easy to manage their maybe affective state, they highly charged. Okay, and then also roles mean here you can see exchange clearly defined role flexibly. It's mean that who's going to take care of the child, or let's say maybe the daughter or the son maybe admitted to hospital for pneumonia. Okay, so the family, maybe the mother or the father, have to adapt quickly, so they have to know who is going to take care of the child at the ward, or maybe who's going to manage the house, so get the outside resources, like get help from the grandparent, auntie or uncle. Okay, so this is actually the we said that this is actually make the family more adapted if they have those kind of skills. The last one is the rate of family change required to cope with gradual onset. Gradual onset, we can say that a chronic one. It takes more time. The disease take more time, maybe to happen in that person. Like as we discussed before, like hypertension, diabetes. So this kind of disease actually allow for more protracted period of adjustment, so that the family actually have more time for adjustment. Protracted means a longer time. So for acute onset, maybe the family need maybe to adapt quick or more faster, rather than the gradual onset. Okay. Okay, now we move to another slide, the course. Okay, the course divided into three. Actually, I already touched this also in the class. If you still remember, the progressive, we give the degenerative disease like spinocerebellar ataxia, or multiple sclerosis. This is another disease. Okay, actually the disease is actually it's a progressive disease. Maybe when first you get this disease, you are still okay, but later on, from time to time, it getting worse and worsen. Okay, like I said to you, one little of tears. So 1 liter of tears. Okay, so 1 liter of tears is a movie actually showing how the progressive illness happen, or condition happen. So we can see from the first, when the person get the spinocerebellar ataxia disease. So what happened, maybe to her first, maybe she can still walk, and maybe after that she can't walk, she become paralyzed. So this is a progressive cause. So maybe as a family, or in a marriage or family counselor, you should understand when your client come and telling you that there may be family members having this progressive maybe disease. Okay, this kind of issues in the family. And the second one is the constant cause. The constant disease is actually referring to, here they say, the initial event occurs after which the biological cause stabilize. After actually the illness or the pain occurs, and after that the biological stabilize back, like what, like constant, like hypertension, diabetes mellitus, you know. This kind of problem actually, when first we triggered or we get this pain, this illness, maybe uh, it's maybe our condition is worse, but later on they stabilize back, right? We have to maybe take care of our eating, diet, lifestyle, you know. So individual or family is faced with a semi-permanent change that is stable and predictable over considerable time span. Okay, so semi-permanent is referring to your lifestyle. So predictables mean something that you can predict. Let's say when you're having a diabetes or hypertension, if you are not maybe control your eating, you know that your maybe BP will increase, you know, your blood pressure, and then the sugar, you know. So this is things you can predict. You are the one who control it, this kind of disease, okay? So the constant also need to be adapted in the family when any of your maybe spouse, your husband or wife, or your maybe children having this kind of problem, you also have to adapt, okay? But maybe it's more easier than the progressive or the acute onset, okay? Okay, the other one is the relapsing or episodic. Okay, the alternation of stable period of varying lengths characterized by a low level of absence of symptom and with period of flare up. Or exacerbation. So that's mean they have a period that low and high, and they flare up back, and then it's maybe become more worse, and then exacerbate, you know. So this condition we can I give you one example, okay, like asthma, like psoriasis, like SLE disease. Okay, this kind of disease actually they have recurrent attack, you know. It's happened once and then they flare up, and maybe they have a time that they heal back, and then they get back that attacks, you know. Strain on the family system is caused by both the frequency and transition between crisis and non-crisis, and the ongoing uncertainty of when the recurrence will occur. It's become a strain for the family when the transition between the crisis happen, you know, the disease happen, and then they getting low back, and then they come back, you know. Okay, this is quite actually sometimes unpredictables also, you know. Sometimes like asthma, when the climates change, you know, so it can happen. Or sometimes when they're facing something that trigger or allergic, also can flare up, or also can maybe exacerbate the condition of the person or the patient. Okay, now we move to another slide, the outcome. So we know that the outcome is what is actually happened after we get all the disease, you know, after we maybe first the onset, and after that's the cause, you know, the progression of the disease, and then the outcome. The outcome they have divided into two. Does not affect lifespan. Does not affect lifespan ni something that actually I mentioned in the class, like you have a knee problem. Sometimes the old people they have a knee problem, like if they walk too much, they have a problem in their knee, on their toes, maybe, you know. So this is, we call it, this actually not really affect their life, you know, lifespan. But another one is the affect lifespan actually also divided into progressive and fatal, and intermediate and unpredictables, you know. The progressive ni like cancer, degenerative disease, you know. But the intermediate or the unpredictable is like the heart attack. We do not know when it's happened, you know. So they're occurring in between the illness cause. Okay, so this is actually we also touched in the class before. So now how does it affect the family? That the question. Okay, we can see here that the major difference between this kind of outcome is the degree to which the family experience anticipatory grief and its pervasive effect on a family life. So we can understand from this that how family perceive, how family accept, and how family bear the grief, the pervasive effect actually will determine the degree uh, and the outcome on family, how it cope, how it adapted. It depends on how they accept, how they perceive, how they experience uh, the effect or the impact from the disease in their family. So when loss is less imminent or certain an outcome, illness that may shorten life or cause sudden death provide an idiosyncratic family interpretation. Okay, let's say when the doctor say, okay, your son or your daughter will not die, okay, because this is just maybe common disease, but suddenly your daughter suddenly die or pass away. So of course you will have some like uh, what we call that, maybe strange or maybe peculiar or maybe some like uh, uh, interpretation, you know, toward the event or the situation, because this is sudden happen, and then the it could happen nature of this illness create a nidus for both overprotection by the family and power secondary gains for the ill member. Okay, sometimes as a family members, we maybe think it could happen, you know. So this nature actually make, you know, actually as the catalyst or the nidus for overprotection in one family, or maybe also as a secondary gains. Okay, as a secondary gains for the ill member. What is actually the secondary gain? Okay, the secondary gain is first, someone is using illness for personal advantage. Okay, the second, maybe the patient or the person who got ill maybe exaggerating the symptom. And the third, maybe they consciously using symptom for gain or unconsciously presenting symptom with maybe no physiological basis. Maybe they want to take advantage, they play like a victim, or maybe they just maybe have maybe small pain but they exaggerate like a big pain, you know. This could happen, you know, in the family also. Okay, and then this is particularly relevant to the childhood illness such as hemophilia, juvenile onset diabetes, and asthma. Okay, now we move to the slide incapacitation. Incapacitation, I think the slide that we stopped in our previous class. So, but I managed to explain few. Incapacitation is incapable, okay, inability, okay. Uh, So this is actually related to any disease or illness that causes maybe changes or inability, incapable to our mind, body, or psychology. You know, like if we may be having Alzheimer disease, we have like impairment of cognition, blindness is actually to sensation, or maybe the movement is like maybe incapacitation, incapable of movement. Maybe we are having stroke or paralyzed, or maybe multiple sclerosis, you know, or energy production like cardiovascular disease, disfigurement like severe burns, yeah, leprosy, medical causes of social stigma like AIDS. Okay, so this is all things that happen and relate to the disease or illness that may occur to in individual. Okay, and then again, how does it affect the family? So as we can see here, this kind of incapacitation need the family members to work together, you know, to maybe cooperate, you know, maybe lending a hand, an energy, time, you know, to maybe cope with the condition in the family. Like if we have one family member having maybe disability, handicap, or maybe get stroke attack, you know. So we have to adjust. We have to take care of them. So it's actually will develop a new culture. It will develop a new way of the family members behaving, interact with each other, responsibility, you know. So as we know, the cognitive and motor deficit of a person with stroke, you know, sometimes they need more, time to take care of them, to maybe care, to maybe look, or maybe feed them with it and everything, you know. Some chronic disease like hypertension, maybe, or maybe some illness like stroke, you know. So the incapacitation is often worse at the time of onset, at the beginning, and magnify family coping issues related to onset, expected cause, and outcome. For progressive disease like Alzheimer, disability, also increase problem, later. And then it's actually also involve the family preparation, you know, the anticipations of change, you know. So this is all actually related to the family planning. Um, to the person who got ill in the family. You know, we have to plan, we have to adjust everything, we have to. So actually, this actually can create also stress. So if you are as a marriage and family counselor, when you are facing this kind of patient or client, sorry, a client, so you have to understand or empathy the condition, how they have to manage everything in the home, how they have to actually take care of the ill sibling or ill person in their family, you know, how it actually happens. Sometimes uh, family members who maybe uh, responsible to take care of the ill person maybe have something maybe to share, maybe they keep on maybe uh, what we call it, the emotion, so they don't express the emotion, they just keep with themselves. So this kind of thing actually eventually will lead into the big issue. So we as a counselor, maybe we need to understand first, and then maybe we can ask them to share with us the emotional burden, the physical burden, or anything that face in the family, and how we can help them to cope with the situation. Okay. So if you see here, this is what actually we are discussing about. 4 common relationship issues for families caring for someone with chronic illness. The caregivers, the family members, especially the parent, you know. First, do not set aside time for themselves. Okay, they cannot, you know, set aside their time. You know, they have to have their own time. You know, sometimes when we take care of other people, we forget, you know, to actually focus to our own matters, our own stuff, you know. And then the second one is other sibling do not get the attention they need from parent, maybe causing them feel lonely, left out, you know. Because maybe the maybe let's say in one family they have like disability child, so the parent or the mom will focusing on the disability child, so the other person maybe will feel abandoned or neglected by their family, you know. So the third one is the spousal relationship become unbalanced as a result of the need for caregiving. I think you can understand. And then the family members tries to do it all alone because they don't know how to ask for support. This is another thing, you know. They try to do everything by their own. They do not know how to maybe ask for help, ask for support. Maybe they shy, you know, to asking, you know. Okay, and then when should the family seek help? Difficulty making the transition from the demand of one phase of an illness to another. Okay, if we can see from the slide here, so what does it mean by the difficulty making the transition from the demand? Okay, okay, this is actually we already discussed in previous slide, like difficulty making the transition, like when someone having an Alzheimer, they always forgot everything, right? When they do something, they forget. When they do something, and then they forget. Like they are maybe boil the water, they forget, and they don't close the the fire. So when they start to wash the clothes, they forget to stop the washing machine. So this is happened to Alzheimer. So when someone in the parent, having this kind of problem, it's very hard to cope. So maybe they need someone else maybe to help, otherwise they will get stressed or burn out, because having take care of someone with Alzheimer, in Malay we call nyanyok lah, right? So this is very difficult. So if the transition also getting worse, among our family members, maybe when they start having Alzheimer, maybe they just maybe forgets maybe once or twice, but after the condition or the transition, it become more worse. So the family member should ask for help, you know and then when to ask for help, to seek for help, when the evidence of the caregiver burn out. Okay, what is the symptom of burnout? Like exhaustion, like short temper, like trouble sleeping, cannot sleep, insomnia. This is the symptom of someone having the burnout. Maybe after spending maybe too much time on um, uh, caring the ill family members. Okay, the other things that I think the point, the big point for us to understand when the family seek help is the changes in the ill family member. Yeah, like say when the ill family member suddenly didn't want to talk to us, didn't want to talk to the other family member, to their mom or their dad. There might be something wrong somewhere. So we have to ask for the help at that time, at the right time. Okay, and the last one is stress or conflict among other members of the family. So when we see that the conflict happen, we know that now we should ask for the help, from maybe the counselors, or maybe from the other relative, or from the other person who can maybe advise, or maybe become a mediator, or maybe become the conflict we call it resourceful person, or manage the crisis, okay. Okay, now we move to another slide, the intervention. This intervention might be useful. You can use the CT, cognitive therapy. You might also use the CBT, cognitive behavior therapy. Or you can maybe in cognitive behavior, you have a cognitive activities, or the behavior technique, cognitive technique, you can actually apply to your client. Because there's no single pain control technique yang proved to be the most effective in relieving chronic pain, many healthcare actually use an eclectic or cafeteria approach to helping their patient managing the pain. Eclectic, like you're using few theories, few techniques actually to help the client. So for CBT, changing a person's experience of pain by changing his or her thought process and behavior. I think you can read on the technique of cognitive restructuring. This is one of the technique, cognitive restructuring in CBT. I think this is part of numerous of psychotherapy, but mostly in cognitive behavior therapy we use it. So it's actually involved in adjusting unhelpful belief, or by identifying and challenging them. Sometimes you can also identify the negative thought. Uh, So, actually, when a person use the cognitive restructuring technique in their daily life, they can manage the stress, they can improve their self. And for the experience of pain, we can also use this by changing our client thought, you know. Other than that, we may also using the education as one of our goal setting, which counselor use CBT by providing brief information to patient about the type of pain, chronic or acute, the effect of depression, anxiety, lack of activity, as well as pain control factor. So in the education phase, patients are encouraged to generate pain experience by writing the frequency of pain in the notebook, you know, time, strength, medication use, mood from time to time, you know. Then there is no need to rely on the patient's memory, and the record will give the patient insight on the factor that affect actually his or her pain. Such insight also help patient in controlling pain in the future. You know, they know what kind of medication or what kind of treatment that cause really big pain to them, you know, or and small pain. So they know, and they know their, maybe from that also they know their threshold of pain. They know how they limits, you know. So um, so then we move to the goal setting, you know, we proceed with the goal setting. Example, a patient behavior management program that targets specific and measurable goals, such as I want to be more active by walking 30 minutes 4 times a week. Okay, this is example, okay. Basically, attitude and belief play an important role in influencing our health. So the pain management program are done with cognitive restructuring, as we discussed before, which is by redefining pain as something that can be controlled and managed well, unlike what the patient feel. So we can improve the patient irrational belief, which contribute to depression and worsening actually the pain. So this is, I think, just a brief introduction on how you can use the CBT in actually helping our client in reducing their pain by cognitive restructuring, by maybe program something that different in their mind, and maybe by journaling, by giving them a logbook, putting the emotion, the pain, everything inside that can maybe give them clear views on what is actually happened and what is actually the experience, and maybe how they can avoid or maybe reduce some part of their pain, some level of their pain, you know. Okay, I think that's all for now for the explanation of the chronic and acute pain. So now we want to move to the instrument. Okay, the instrument here is a patient assessment of chronic illness care, acronym as PASIC, you know. The PASIC is the abbreviation of this instrument. So when I say PASIC, it's referring to the assessment of chronic illness care. Okay, it's actually was developed by the Wagner and colleagues, 1990. It has 20 item patient report instrument that assesses patient receipt of clinical service and action consistent with the CCM. What is the CCM? Okay, CCM is a chronic care model. I think I already mentioned and I already draw the picture of CCM and I put in the class, and we have some activities. I think the very enjoyable activities that actually we did before. Congratulations to everyone who can actually did very well in that activities. Okay, now we see again the respondent rate how often they experience the content described in each item during the past 6 months. Each item was scored at 5-point scale, like a scales, from 1, no or never, to 5, yes or always. Patient rated care received from their primary healthcare team, not just their personal physician, for the chronic illness that they identify as most impacting their life. The written version of the passage takes 2 to 5 minutes to complete. The 20 items were selected or modified from a larger pool of 46 items generated by a national pool of experts on chronic illness care CCM. Okay, before they got 46. Now I think the brief version is 20 items. The internal consistency alpha for the overall passage score was 0.69. It's a high value for the alpha Cronbach. Okay, this is the CCM model. Okay, I think we already see before this, right? So if you can see from this circle, we actually have 5 important things. 4 coming from the health system, organization of healthcare, the health system like hospital, or the clinic or the private, hospital. The first, they must have the self-management support, and then the delivery system design. The third, the decision support, and the fourth is clinical information system. Okay, actually this CCM model want to want to describe how the patient can get functional and good clinical outcome when we have the all combination and the good system in the healthcare plus the community. So as I mentioned, 4 in the health system, like the first one, self-management support, like in hospital or in the clinic or private, have 24/7 access, have convenient service, a good communication, maybe reminders, alert, planning, empowerment, engagement. This is all in self-management support. The interaction between the healthcare provider and also the patient, it will become the support for the patient to improve from their disease, And the second one is delivery system design. Is actually referring to how the care coordinate the interoperability, the interoperability, like I give you example, a diabetes patient, when they go to hospital, maybe they need to go for one section checking their blood, or maybe to the other department to check their eyes, So the health provider, the healthcare system must provide this kind of actually system, the interoperability. So they can operate in few they can operate in few sections that actually the patient can get their services. And then the medical jargon, like how the doctor actually deliver the terms, maybe when they are using the maybe layman terms, it's easier for the patient to understand, the timeliness, how the patient get the treatment in the right time, the policy and networking design. Okay, this is all in how the system delivery their services. Okay, this is why they call the delivery system design. And the third one is the decision support. The decision support is including maybe the pamphlet, the protocol, the guideline, the info button, graph chart. Sometimes when maybe you are a diabetes patient, you go, they give you some pamphlet, maybe they give you some checking, or sometimes when you go to the physiotherapist, they give you one guideline, to do this and that. This is how you can make your own decision, or you can do by your own, like sometimes diabetes also, they can check the blood, the sugar by their own self, So the last one is clinical information system. How actually the healthcare provider, the organization of the healthcare provide the information. Like some of the healthcare provider, hospital, or maybe the advanced clinic, they have all the personal health record, the patient portal, the telehealth, the smartphone, the so many things they can provide. The maybe the digital or the device, to check anything anytime online. You can check your own maybe progress, report, medical and everything, you know. So this is the information system. Okay, so this is what actually provided in the healthcare system plus the community. Community also play the vital role, like, you know, being the resources, or maybe sometimes the community have also the policy, you know, to govern, to actually the control everything, also the how the community interact, how the community perceive, how the community support, you know, this is all under the resource and the policy giving by the community to the particular person or the ill or the disease, those who are having a disease. Okay, and then when you see the illustration here, the picture, the model here, they also have another two circle: inform activated patient and prepared proactive practice team. So when the prepared proactive practice team, like doctors, nurse, matron, MA, you know, the medical assistant, also we have a knowledgeable or informed patient. They have the productive interaction between them. So finally, we can have the functional and clinical good outcome. So maybe when the patient have all these services, got all the provided that I mentioned just now, they can maybe heal faster, or maybe they can have a very good progress in their disease. Okay, so this is the CCM model. I will give you another notes to make you more understand, to maybe the additional reading for this CCM. Okay, okay. Now we move into the PASIC back. Okay. Okay, now we move to the basic instrument. As you can see here, this is the instrument. So this is the question. When I received care for my chronic illness over the past 6 months, I was first, in the first three question, you can see ask for my ideas when we have made a treatment plan. The given choices about treatment to think about. Ask to talk about any problem with my medicines or their effect. So you almost, or you generally not, sometimes, most of the time, or almost always. Or the first one, almost never. Okay, so this is the 20 item you can see from the instrument. I will provide you the complete instrument later. And now we move to the scoring. Okay, before that, they have 5 construct in this PASIC instrument. First is patient activation. Okay, patient activation is actually identified by the item number 1 to 3. And then the second one, they want to gauge the delivery system or the decision support. This is what we have learned in the CCM model. And the third one is the goal setting. And then the fourth construct is problem solving. And then the fifth is the follow-up or coordination. Okay, some construct have 3 item and some construct have 5 item. So how to score? We take the average of the item. Okay, the average of the item. That's mean if 1 to 3, the answering scale, we have the 1 to 5, right? 1 to 5. Jadi, so if the highest is 15, okay. If item number 1 until 3, when we want to take the average, we take 15 and divide into 3 item. Okay, from that we know the mean score. Also the delivery, we have 4, 5, 6, 3 item. Okay, same, we divided into 3. And then for the goal setting construct, we have 7, 8, 9, 10, 11, 5 item. So that's mean we have 25. So if 25, and we have to divide with the 5 item, so we will get the mean score from lower to high. 1 to 2 is low, 3 moderate, and 4 to 5 is high. So you can see from the second interpretation of score here at the table. So the patient activation total mark and divide with 3, you can get the mean score. I already made the calculation here, so you just referring to this. So for 4 to 6, we divide into 3. For 7 to 11 construct, we divide into 5, and then 4, and the last one is 5. So if we get the score 1 to 2, we can describe as low, and then for 3 is moderate, and 4 to 5 is high. Okay, so the last one you can see the slide interpretation. So if the patient get high, mean get high for construct patient activation, the interpretation is the action that solicit patient input and involvement in decision making is high. So if the patient get low, mean it's low. Okay, so the delivery system is referring to the action that organize care and provide information to patient to enhance their understanding of care. So if the score is 4 to 5, that means the patient get high delivery system or decision support. So same like goal setting. So they referring to acquiring information for a setting of specific or collaborative goals. Mean they get some information about the specific they want to achieve in healing their disease, you know. So or get acquire information about the pain, about the planning, you know. So this is actually happen also in the healthcare provider. If they got it high, that means they have a very good goal setting. But the other construct is problem solving, considering potential barrier in the patient social and cultural environment in making treatment plan. Okay. Sorry for construct number 3, the goal setting. I want to add a bit for collaborative goals. That's mean, you know, when we, you know, deal with the patient who have diabetes, maybe we want to, our goal is maybe want to prevent the diabetes patient from having an eyes problem or kidney failure, you know, high glucose. So this is actually few things. And also maybe the dietitian, the doctors, maybe the optometrists also have to collaborate in achieving these goals for the patient. Also the maybe the nurse or maybe the matron or maybe the medical assistant, you know. So this is actually in order to achieve the goal, to help the person who have ill. Okay, so the fourth construct is the problem solving. So considering potential barrier and the patient's social and cultural environment in making the treatment plans. So if the actually this is referring to potential barrier, like maybe the patient don't have maybe transportation to go to the hospital, you know. So the patient social and cultural environment is sometimes we have to know you know, what kind of perception among family or in a one culture toward the illness, you know. Sometimes when someone have you know, like SLE, so some people will maybe afraid to near to them, or maybe you know, thinking that they will you know, infect to other the disease even though they're not. Same like HIV, AIDS, you know. So other than that, like, you know, when the doctor maybe have diagnosis someone with some illness and they ask to do the lumbar puncture, in Malay ambil air tulang belakang. So we have like some stigma that when we do that kind of treatment, patient will get paralyzed, right? So we avoid to do that, but actually it's not. So this is kind of like social and cultural, maybe environment or barriers that happen. And the last one is the last construct is follow up. or coordination. So arranging care that extend and reinforce treatment and making proactive contact with patient to assess progress and coordinate care. So for high risk disease, sometimes the doctor or the nurse will go to the home, visit, to check everything. So this is arranging the care that, after maybe follow up after they get service or treatment in the hospital or the healthcare provider. Okay, so when they have high score, that means it is good, but low score mean they still lack on getting the comprehensive services in order to reduce the symptom or healing of the particular illness. So this is the instrument. I think all of you can understand based on the explanation. As in brief, basic F5 construct. In each 5 construct, they have 3 to 5 item with gauge the construct. So how to scoring? I already mentioned. We just take the average mean score. So then the interpretation will describe what is actually the patient get from the treatment, from the healthcare provider, from the what I explained from CCM model. The healthcare system and prepared proactive practice team and informed activated patient, the productive interaction between them can lead to the functional and good clinical outcome to the patient. We can have a very good progress in patient disease, and also maybe also affect the family members, also maybe the goodnesses for the family members in arranging the services and treatment for their ill family members. Okay, so understanding this instrument maybe will help you to administrate to your client, and then you can know actually which part of the healthcare system still lack in client access. So we know that maybe the client don't get this, or maybe get this but in a low level. So we know that which part should be increased, which part should be amended. So we can suggest our client in order to make sure they got the comprehensive service treatment for holistic approach in finding their solution or healing. Okay, so I think that's all for my explanation. I think maybe quarter or half from our previous class regarding to the topic of assessment related to acute and chronic illness. Thank you very much for your attention. I hope you can understand well. And if you have any problem, you did not understand at any part of my explanation, you can just text me or call me to ask me further for clarification. Okay, inshallah, we will meet again. I pray that all of you can get a wisdom, easy to understand, not just my subject, but for all subject that you take for this semester, inshallah. That my prayer for all of my student in assessment and appraisal in marriage and family counselling class. Till then, Assalamualaikum warahmatullahi wabarakatuh and selamat sejahtera.